we'll go ahead and get started. Just wanted to take this opportunity to welcome you all to today's roundtable. We're going to be focusing on honoring donor decisions. So just to get started, I'll go quickly through the agenda, but we'll also do a connect to purpose. And then we have Dominic Adorno here to talk through some of the things that we're doing internally at LifeCenter, and then also just give a little more context about our plans for the future around honoring donor decisions. So we'll start off as we normally do with how we're doing on our progress for our campaign goals and how individual hospitals are meeting those goals, and I want to give some recognition to them. And then we'll do an analysis of our donor registry opposition data. We've been doing a lot of work over the past couple of months to really identify what are the things that we can do internally at LifeCenter to make these occur far less often, because I think that's what all of us would prefer. So we have some good data that we'd like to share with you all and give a preview of what's changing and a timeline of the events that LifeCenter is planning related to this work into next year. And then also just some items that we would maybe hope that you all would be working on. We're hoping to have a hospital highlight from St. Joe's Medical Center in Bellingham. And then of course, a lot of time for Q&A and open discussion. So before we get started on all of that, I do want to do a connect to purpose. This is Kaylee. She was 10 years old when she passed away, unfortunately, at a very young age. She was from Fairbanks, Alaska, and lived there with a pretty large family. But I love the quote from her mom that she was definitely not a princess. Yeah. She was a force of nature, so much stronger than this earthly body could contain. So she was super into being a warrior hero in her video game, and just really a strong willed individual, it sounds like, even at such a young age. So she actually, as I mentioned, she passed away at 10, but she was able to be an organ, eye, and tissue donor. She donated her kidneys, her liver, and her heart valves, and then also her corneas. And her kidney recipient was a 59-year-old man from Washington, and her gift saved him from a lifelong struggle with diabetes. And he was really into books, and as it turns out, so was Kaylee. And her family actually learned after she passed away that she would donate her books to the school library so that other people could enjoy them. So just a really wonderful, giving young spirit. And so Kaylee's actually going to be our Rose Parade honoree. Each year, LifeCenter sponsors a donor family to go to the Rose Parade and be featured on the Donate Life Parade float. So Kaylee will be our honoree for the 2023 Rose Parade, which will happen on January 2nd. And her family will get to participate in a finishing ceremony of her florograph. So for those of you who don't know, all of the floats are all made with, organic items, all of it. And so they make these photographs of their face. And then the family gets to finish a portion of it before it goes off to Pasadena to be in the Rose Parade. So you'll be seeing a lot more information about Kaylee in the coming next couple of months as we prepare for the Rose Parade. But we wanted to take this opportunity to introduce her story and use her as our connect to purpose for the work that we're going to do today. So as you all know, what our In the Wait campaign objectives are, really looking to connect with families. That's something we're going to be talking about today and that we talked about in the September roundtable, eliminating early extubations and honoring all donor decisions. And we really do believe that when we work together to do all three of these things, we can achieve a 75% or higher donation rate. So just looking at the hospitals who are actually already doing this, I want to recognize these hospitals who have a 75% or greater donation rate year to date. So this list is getting a little smaller as we get closer to the end of the year, but just really want to recognize these hospitals because it is not easy to maintain this high donation rate through 9.5 months of the year. So thank you to everybody at these hospitals who are doing this work and making sure that we're achieving this high donation rate. And as we have been doing, want to recognize those hospitals that are really close to this high donation rate as well. It is, like I said, it's not an easy process to meet these goals. So we also want to recognize these hospitals who are very, very close to that rate. And just thank you for all of your hard work as well. So in terms of eliminating early extubations, we are moving down. Last year, 6% of all of our donation potential were early extubations. And so that is either a missed referral call that came in after the patient was extubated, or an extubated while following, which means we got the referral, but while we were following the patient, they were extubated either prior to us determining that they had donation suitability or being able to speak to the family. So we are moving in the right direction. We'd obviously like to see more progress, but I know all of you are working hard on your key initiatives, and we have a large percentage of the hospitals that are participating on In the Wait have implemented an eliminating early extubation key initiative. So we believe that as we get more and more of those implemented, that we will see this number continue to drop. So it's very encouraging. These are the hospitals within our service area who have not had one early extubation this entire year. This is a very difficult thing to do. I mean, there are a number of hospitals that haven't had an early extubation on a donor or a potential donor, but these are hospitals who haven't had an early extubation on any referral that they have referred. So really something to be proud of, because it is easy to miss one on occasion. So they are obviously doing great work to make sure that that does not happen. We're going to, as I talked about, spend time today talking about honoring donor decisions. Our primary focus will be around the DCD side of this. And as you all know, we've been working on decreasing those patients who either are declared brain dead or appearing brain dead on those potential donors having donor registry oppositions. And we are seeing excellent progress here. You can see that our number has really just kind of dropped off, which is what we wanted, and what all of you have worked to put systems in place to where these patients are declared, and then we do move forward with those patients when they have been declared brain dead and have already expressed their donation decision. So just want to acknowledge everybody's hard work on this, because we are meeting the goal that we set out at the beginning of the year to decrease these, and seem to be continuing to move in the right direction. So these are the hospitals who have had at least one registered potential donor and have been able to honor all of those donor decisions. So there are some hospitals probably that have had potential donors, but maybe they weren't registered or whatever, that wouldn't appear on this list. But all of these hospitals have had at least one registered potential donor, and those donors have gone on to become donors. So really want to recognize these hospitals who have honored all of their donor decisions throughout the entire year. The next thing is connecting with families. And as we've been talking about over the past couple of months, this is a newer goal, and we're starting to get some good information, good data around what's really important related to connecting with families. And Dominic will share some of the work that we've been doing. And I have been reporting on the collaborative request rate, which I think is important. But I think what we're finding is that potentially that timing of the family conversation is actually more impactful. And so Dominic's going to share some data, and we're going to continue to be working on what we can do together as both hospital and LifeCenter to really make sure that we're hitting that perfect timing when we connect with families. So we'll have more information, but this is just the trend that we're seeing in collaborative request rate, but we'll have more information about the timing as we continue to move forward and into next year. These are hospitals that have 100% collaborative request rate year to date, meaning that all of the conversations were done in collaboration with LifeCenter with a plan, and the plan was followed. And actually one of the things that's interesting is we're seeing that when we identify that appropriate timing and we work with the hospital on making sure that we have a timely connection with the family, that makes it easier to not have unplanned mentions or a non-collaborative conversation, because we're literally planning for that conversation throughout the entirety of the referral. So it's working really well. But with that, that's kind of the high-level overview of how we're doing against the goals that we had set out. And then I'm going to turn it over to Dominic to talk about our data and what's next.
Thanks, Rachel, and appreciate the opportunity to be here. I have Pat, who joined me in the background here, my mannequin. So hopefully that will give me some street cred with the clinicians on the call, but if not, hopefully the presentation will. So we go on to the next slide. So this is just a general kind of kickoff point of reference here. And this is something that HRSA puts out every 5 years. It looks at the national, conducts a national survey of organ donation attitudes and practices. And the latest one was in 2019. And I have the reference here. We can share these slides so you can look at this yourself. But overall support for organ donation throughout the U.S. remains high at a little over 90%. It has decreased a couple of percentage over the past couple of years, but it's still relatively high. And half the respondents who participated, I think it was around 10,000 people who participated, had signed up to be organ donors. And of those who hadn't signed up, over half of them said they would sign up or want to donate their organs after death. And about 9 out of 10 of them had said, had they known their family members' wishes, they would choose donation. And even if they had known them, about 68.8% of them said they would donate their loved ones' wishes. So this kind of just gives some context when we're talking about what we experience in the field is different from these numbers. We recognize that is when when families are experiencing acute trauma and grief, sometimes that ability to connect in a way that allows them to experience generosity, it's just not there. But we know in a controlled survey setting, there's a high support for organ donation. Next slide. So when we look at those patients who are registered, LifeCenter's data, and those in particular who are not declared brain dead, those are donation after circulatory death potential. About 73% of those families had a desire to support their loved one's wishes. But the number one reason we get from a decline is due to timing. So it's not a true opposition to the registry. And then I think it aligns a little bit more with what we're seeing those survey results. But it's like we've made the decision to withdraw support and we want to do that now. So LifeCenter is thinking about what we can do further upstream to be able to honor these decisions and have timing become less of a reason for decline. So next slide. When we look at our data overall, we own some of these outcomes, right? So this is just a graph of 16 of the decline cases where timing was a decline in registered patients. And the blue marks are kind of the time frames in which we gave the family that we could make this happen, right? So the blue being the minimum and the orange being the maximum. And the gray bar down below represents kind of the goal timing. So we should be able to make donation happen within 24 hours. But we recognize that that's, I think, a bit long, and we want to be able to reduce that down to 12 hours or even fewer. So this kind of just says LifeCenter owns kind of the part of this when we're communicating what the time frame is to a family. So we are working internally on developing protocols to be able to facilitate organ donation much sooner. Now, we were able to do this pre-pandemic pretty often. So we were able to make donation happen in less than 8 to 12 hours on a good portion of our cases. Certainly the pandemic, the testing requirements that come along with that have made it a little more challenging, but we know we can do more internally to support the family's desire to withdraw support and honor the patient's decision at the same time. Next slide. So how are we going to achieve that? So again, LifeCenter is accustomed to being able to make cases happen quickly. Again, the pandemic has certainly presented some barriers for that, but what we are doing internally is building a larger surgical team. So we are going from 2 primary surgeons who are able to do the organ procurements to 5 by early 2023. So being able to make sure that we have the proper resources to address all the recovery needs. Serologies, looking at setting up serologies on patients who are registered earlier. That certainly is an impact because they wouldn't want to transplant the organs until those serologies came back. That includes COVID testing, so not serological testing, but we want to make sure that COVID testing is sent off and we have the results prior to transplant. Recognizing that one of the big barriers now is just securing OR times. We know that all of our hospital partners are experiencing staffing challenges, so being able to work further upstream to let you guys know when we are anticipating timing constraints and working with you to get those ORs available, and then just being a little bit more efficient in our process. So we are developing a team who can help build our donor chart remotely and further upstream, so it'll allow us to move to organ allocation and recovery sooner. I do want to just make this a dialogue as much as we can. So Penny, thank you for sharing your comment. So she said, instead of trying to speed up donation, can we not change the expectations with public education? The survey of attitudes and practices didn't evaluate what people don't know about donation. All the positives could be based on a thin depth of understanding. So certainly agree, there's a lot of efforts underway, Penny, beyond just what the survey shows, to increase the public's awareness of donation. I think the bigger question is, how granular is that education? Do people recognize the time frames in which it takes to make donation happen? All the things that are required for donation to happen in terms of testing. And then what does it mean to sign up for the registry? So certainly I agree with you, more education could be done, but that is part of what we're doing in the moment as well. So this is where our family support team is engaging with families to kind of go through the process. And what we're doing is working further upstream. We'll talk about that in the next slide here, about what we're doing to connect with families earlier in the process, so timing is less of a barrier. Okay, slide please. So this is what I was getting to about our ability to connect with families earlier. Certainly, we often hear, had I only known about this a day or two ago, I certainly would have wanted to make it happen, but we have made a decision which I'll support, and that's what we want to go with. So we have embarked on an initiative called the Initial Donation Council. This is where we conduct a family readiness assessment, and if that family is ready based on our criteria to talk about or hear about donation, we will have that conversation. So you can look on the right here, you see two categories: the traditional CFC, the CFC stands for Compassionate Family Conversation, and then that timely connection, and that's our Initial Donation Council and our ability to work and provide that information to families earlier. And what we've seen is certainly the numbers are much smaller as we just got this started, but the results are encouraging. Primarily in the DCD population, you can see that a traditional conversation, we had a 69% authorization. And when we had it earlier, or more timely rather, that went up to 93%. You look at the non-registered patients who are not branded, the DCDs, the authorization rate in a traditional pathway was 25%. And when we had a more timely conversation, that went up 20%, up to 45%. So what about phone conversations? Does that make a big impact? And Rachel references earlier, it's more about the timing of the conversation than it is whether we're having it in person or not. You can see, same thing, a small increase on a DCD registered from 90 to 93, but our brain-dead non-registered went from 40 to 63%. So overall, we increased our authorization 5% by having more timely conversations than we did by having them in as a traditional pathway or in person. Next slide. So what's changing? Well, starting the first quarter of 2023, LifeCenter will be moving to honor all donor decisions independent of their mechanism of death or donation pathway. So this will include donation after circulatory death in advance. Rachel. So the goal always is to have a collaborative effort with LifeCenter and our hospital partners. And the desired outcome is to ensure that the autonomy of the patient is honored while also supporting the families through grief and loss. Advance one more time. And as we obviously get closer to that go live date, we will provide more information and communication on the specifics of kind of how we're all going to operationalize this. Next slide. So why is this change happening? Obviously, the need for life-saving organs far outweighs the total number of organs available. 17 people on average die every day waiting for that life-saving gift. Next slide, or next. So by law, people over the age of 18 can make independent and autonomous decisions regarding the gift of their organs and tissue at the time of their death. And based on both the urgency of the need, the state laws in our service area regarding donor registry, it's critical for us to honor those individual donation decisions despite opposition and regardless of donation type. And again, our research has showed us that the opposition is far less about the actual registry and more about the process. Penny, we've had conversations previously about what we can be doing, partnering together to work further upstream. So again, I think the initial donation consult, having more timely conversations, is our attempt at working further upstream, but also being able to make sure that we have the resources in place so when all those efforts are put forth and we're still not able to agree on or have the family support of the registry, that we're able to expedite that recovery to make this as palatable for all involved. Next slide. So, you know, the UAGA in terms of state law is pretty clear on kind of how do we honor donor decisions and what is reasonable for the OPO in terms of being able to assess that suitability and make donation a reality. So this is just directly from the UAGA. It says when a hospital refers an individual at or near death to a procurement organization, the organization may conduct any reasonable examination necessary to ensure the medical suitability of a part that is or could be the subject of anatomical gift for transplantation, therapy, research, or education from a donor or prospective donor. If you can advance one more, I think one of the questions we often get is, well, what if they have an advance directive or they have a DNR? How does that, does that conflict with the registry status? And again, there's some language from the UA that says during the examination period, measures necessary to ensure the suitability of the part may not be withdrawn unless the hospital or procurement organization knows of a individual that expressed contrary intent. So if we don't have a documented, what's the word I'm looking for, contrary intent or reason for they don't want to be a donor, a declination, then that is not perceived as a conflict there. What I want to draw your attention to is the next slide, Rachel, and I think this is a very helpful reference document, and we can share this with anybody who's interested. So anytime that there's looking to bring uniformity in state law, the National Conference of Commissioners of Uniform State Laws gets together. These are judges, attorneys who work to look at, see how they can bring uniformity across different states, and the UAGA was one of them, one of the laws they worked through. And what's unique about this process and this document is they document their intent behind every part of this legislation. So if you're looking, it's very hard to interpret the UAGA sometimes at face value. So if you want to understand what their intent was when they're writing the law, this document, it's like an 80-page document, will go through paragraph by paragraph and walk you through exactly what they meant when they were writing the law. I think that's helpful when you're considering policy development, or if you have questions internally on what it means to, reasonable timeframes. What does it mean for the OPO to be conducting suitability, and so on and so forth. So again, not going to repeat this here. If you can hit advance the next part, Rachel. This is kind of where, I talked about the conflict between an advance directive and a document of gift. So if you're just reading the UAGA, you may not be able to interpret this, but there's a section that says very specifically that a general direction in the power of attorney for healthcare or advanced healthcare directive that the patient does not wish to have prolonged or have life prolonged by the administration of life support systems should not be construed as an expression of contrary intent. So because you have a DNR or an advanced directive, that should not overrule someone's registry status. Those things should be worked out with the family in real time to kind of go through which process they want to follow, the advance directive or the donation. Next slide. So next steps and action items on behalf of LifeCenter and our hospital partners is we want to make sure donation policies accurately reflect your position on the regulatory requirements and applicable state laws. We're here to help support that. We want to consider implementing an escalation process to help provide guidance and clarity for staff when potential opposition is happening in the moment. And finally, provide clear communication to any potential stakeholders or staff who are impacted by this process. And I've said this to many of you on separate calls, we recognize donation is a high acuity, low frequency event, but this is what we do. And we have a fantastic hospital development team who's always available to help with some of this, or with all of this rather. So that's, I think, all of my part. So Rachel, I'll kick it back to you.
Yeah. So we will have time for questions shortly, but first I'm actually going to turn it over to Brittany, one of our hospital development program managers, and she's going to introduce our contact from Peace Health St. Joseph Medical Center in Bellingham to talk a little bit about how they're approaching this process. So Brittany, I will let you go ahead. I think you're muted. We can't hear you. How about now? There you go. Perfect.
Great. All right. Well, thank you so much. And my name is Brittany Hurley. I'm the Hospital Development Program Manager for hospitals in the North Sound of Western Washington, including Providence Regional Medical Center in Everett, Skagit Valley Hospital, and Peace Health St. Joseph's Hospital. And today I'm excited to introduce Jen Moyes from St. Joseph's Hospital in Bellingham. And Jen is the Director of Critical Care at Peace Health St. Joseph's Hospital in Bellingham, Washington. She has been our liaison to their donation program for many years, and she is our designated site champion for the End the Wait campaign. Jen has been very helpful and effective at progressing the work within their donation program, and this has continued into our work with our key initiatives. So today we've asked Jen to come and share her process for how she has approached preparing their hospital donation program to support and honor patient registry. So welcome, Jen. And to kick off our discussion, can you share with everybody here what your approach was to preparing, updating, or adding to your process or policy to better honor donor registry?
So one of the things that I did, LifeCenter was able to send me a sample escalation policy around this, and so I took it, I modified it to work within our facility, and it's still a work in progress, and I probably have a few more months in front of me of work, but I wanted to at least get the first blush and hear what people's reactions would be. Because I had a situation about 1.5 years ago where this did actually happen inside of my hospital, and we were scrambling to try to understand what we needed to do. So I took it to my intensivist, my critical care committee, just to share what the initial process would look like and what they would need to know to be able to say, how would this work and what would this look like in our ICU? Excuse me. And so anyway, as I did this, I got some really great feedback from them, and knowing that wording is really, really important, and the names that we use to pull groups together is important. I inadvertently said, let's have a care conference. And my intensivist says, no, this is not what we want. We're not part of this process. And when I went back to the policy and I looked at the verbiage, we really made sure that we had the right verbiage and called it something very different, which was a huddle, and really put in what those guidelines would be to bring a huddle together. I also brought this in front of our AOCs, which are a lot of our directors here at St. Joe's. And because it was a piece to say, what would you do? What would you want to know if this happened when you were on call. And so we talked through that. And inside of that, I learned I also need to, I'm bringing in legal. I'm also bringing in our risk management to make sure that we're absolutely balanced and we're in alignment with our organization before I send it to legal and then bring it back. Brittany, that was probably way too much, but.
No, that's great. And you kind of answered this next question, but in case you left anybody out when you were explaining, who from your hospital did you include in this process?
So this is an ongoing process. My intent as I do this, I needed to do the touch the water to see where I needed to navigate, but my intent is to make a very large road show as we start to get closer to finalizing the escalation process, because I want to bring this through our emergency department, our house managers. I want to work with spiritual care, anyone who may be involved inside of this process. I need to make sure that they're part of this. I need to bring this to my frontline nurses as well, so that they understand and know that their voice is being heard and how we're balancing our internal voice as nurses along with what our patients' wishes are and being able to work with our families. And so those are my stakeholders at the moment, but it may grow as I continue to learn. My biggest thing inside of this is making sure that I'm listening carefully as I'm sharing the information so that I'm continuing to pull in all the rest.
Great, thank you. And then another question that I have for you is, what have you been able to successfully implement so far? And then what else do you hope to accomplish just to support this process change?
Well, with organ donor opposition, I haven't been able to implement anything except awareness. Awareness that this is something that we all need to know how best to react and be able to navigate. But we don't have concrete processes put in place because I need to finish the navigation process that I'm working in front of. But the more that people are aware, our employees are aware of all of this, it will help to stimulate the right conversations and keep organ donation in the forefront of our minds.
Great, thank you. And then finally, what other learnings or takeaways would you share with others looking to do the same thing in their facilities?
Please don't reinvent the wheel. Borrow from others, and share lots. As you tell the story through your facilities, I think it's important because that's where some of the richest learnings are. But if you have the ability to take a template and work on it from there and versus building from the ground up, it's easier. I won't say it's faster, but it's easier and gives you a place to work from.
Great. Thank you so much. Thank you for sharing, Jen, for sharing your experience, your advice. It's really great to hear. And then I guess, are there any questions for Jen from the group? I don't see anything coming through the chat either. So I think you did a really good job.
I'm curious.
Explaining.
Yeah, I would love to open it up just to any questions in general around what Dominic said, or if there's other hospitals that are kind of in a similar place to Jen that might be willing to share any additional learnings, or what questions do you all have in general?
Hey, Rachel, it's Dominic. I'd like to actually explore Penny's comment a little bit more. So she had referenced changing the expectation of the public. So Penny, can you weigh in a little bit more on what you meant by changing the public, or the expectation of the public?
Sure. I think that can you hear me?
I can, yeah.
Okay. I think that you already touched on it a bit indirectly, Dominic, and that you said that, when you do your surveys with the public, that's a little different than when a family in crisis is approached. I think you already touched on it some. So one of the things that, and I'm trying to, as the previous people were talking, I'm trying to phrase this question in my head. Historically, there's been a bit of a gag order on people in the hospital bringing up donation in any way, shape, or form. I understand the intent of this, so that we don't initiate conversations that we can't participate in fully and accurately. I get that completely, but I think that there is an abyss between talking to people who are not in crisis in the community and then launching this topic on people who are in crisis in the hospital. And I want to figure out how we can fill that gap in between. So example, there is no restrictions placed on motor vehicle administrations asking 16-year-olds if they want to be donors on their licenses. They're not required to give any education. They're not required to give any support for that. It's a black and white question. There's no context, no education, no nothing, but there it is. And there's no challenge to that. In our 5 wishes document that we used to use historically to help people with advanced directives, this was a very detailed end of life planning document that included what music you wanted played at your bedside, and do you want somebody to wipe your face? I mean, it was really detailed. And one of the things that was in there was, would you be interested in organ donation? There was never a challenge to that either, that we were, bringing up something that we couldn't talk about. So it makes me wonder if there's some opportunity there, whether it's an FAQ sheet that's available in a couple of different places in the hospital that can be in front of folks when they're not in crisis, and when they're looking for something to read. You're not in a waiting room and they're bored, where some of these little pieces that are sort of unknown to the public might be able to be addressed. So it's not such a surprise. You know that we started our Wall of Heroes project here at St. Vincent Healthcare, putting donor portraits on the walls to try to increase the dialogue around donation. I can't say that it's resulted in more donors, but I sure can say it's resulted in a lot of conversation. And that's what I'd like to find some way of doing, filling that gap between the public that think it sounds like a wonderful and beautiful thing and the patient family in crisis who just want it to be over with. How do we fill that gap and bring people to crisis where they already have some exposure, they have some understanding? Some of this is not a surprise. When you say to them, it might take a day and a half, 2 days to match your father's organ, it's okay with them. They're not deterred by that because it's not a surprise. How do we fill that gap? That's what I'm looking for.
Yeah, I think you make a great point. So I completely agree with you that more could be done to educate the public. I think, the balance that has been, we try to achieve, I think, as an industry about, and I'm assuming how the regulations were written about the OPOs being the one who have that conversation with the family, is just being able to give them the information that reflects the process as it is now. And I think the challenge is, if you're not involved with donation often, can you speak articulately about kind of the process, the timeframes and all that? But how do we fill those gaps is, I think, a really relevant question. I love what you're doing in the hospital there. And I think we can do more of that throughout the rest of the hospitals in our service area. So that's something that we can consider is, certainly we have toolkits for hospitals and healthcare providers, and certainly have pamphlets and stuff like that about donation. But how do we increase the visibility of those documents? How do we partner with programs like you're doing, and the visibility in the hospital of the way you're honoring patients and stuff like that? So the other thing that we're doing is really just training our staff on it's the science of connecting with families, right? So people are in this fight or flight mode, and it's like, how do we get them out of that parasympathetic spot and get to more of a place where they can experience generosity and even hear about donation? So we're training our staff to have those conversations. That's what we're doing in the moment, being able to connect with them so they can, hear about donation in a way that they can maybe experience generosity. But to your point, Penny, what could we be doing further upstream? So there's a larger public domain campaign out there working at community events. That's ongoing throughout the, throughout the country. But what I think we can do more of is get that visibility in our hospitals. Anyone else have thoughts on?
There was a,
I was just going to say, does anyone else have thoughts on what we could be doing in your hospitals to share the message of donation and talk more about the logistics of donation so families feel more informed when that time comes, similar to what St. Vincent's have done?
not directly related to what you were just saying, Dominic, but it was something that when Penny was talking about the gag order, I do think the timely connection piece and these initial donation consults that we've been doing, and me alluding to the fact that we're seeing less unplanned mentions, I think it's really because the timing of those unplanned mentions or those mentions that were done by the healthcare team was probably right, but because we weren't really collaborating as closely around the timing, it made it more difficult for us to actually partner to talk to the family at the right time. So we're seeing some initial information that perhaps those timely conversations are actually helping with that kind of gag order perception and an ability for the healthcare team as well as LifeCenter to partner in a more productive fashion for the family. It looks like Eric put a question in the chat. What bioethical checks/balances are in place to preserve the organ donation process in the context of speeding up the recovery? Can you say a little bit more about what you mean, Eric? I just want to make sure that we're answering the question exactly. I don't know if you can unmute.
I don't know if you can hear me.
Yeah, it's a little quiet, but I can hear you.
I just would want to make sure that we're not applying too much pressure on the family to make a quick decision. I want to make sure that we're, offering enough time for the patients to declare themselves. I mean, I have close family members and friends that have, had their child, for instance, drown in a pool and was pronounced brain dead, and now this child is living an absolutely normal, functioning life without any deficit. So I'd want to make sure that we're preserving bioethical checks and balances, making sure that we're making appropriate decisions rather than quick decisions.
Yeah,
I think
question.
that's
Eric, I was just going to add that. Yeah, I was just going to add that the speeding up is not our goal. Our ability is not to speed up the organ recovery; it's to be able to facilitate the organ recovery in a time frame that's within a reasonable amount of time frame for the family. So if the family says we want to withdraw support right now or today, making sure that we have the resource in play to be able to make that happen. It wasn't any intent, or the goal is not to speed up the recovery on the family end of it. It's only driven by it's really driven by the family. So they're saying, we want to honor our loved one's decision, and we can't have this go on for 2 more days. We want to make sure that we have a practice in place, make sure that we have teams there, hospital has availability, so that we can honor their choice to withdraw life support in a time frame that makes donation still possible. And again, obviously honoring that donor decision. Does that make sense, Eric?
Yeah, that makes sense. I appreciate that. In terms of, what would best serve my department, and I've had this conversation with my coordinator, Matt, a few different times. The best recoveries, the best collaboration with the family is when there is a organ donation representative at the bedside, kind of walking the path with the family especially given our staffing shortages and our new boarding issues in the emergency department here. When you all are able to provide somebody to the bedside to help smooth this process, it goes way better than when it's a phone tag issue over the phone and things like that.
Dominic, this is Penny in Billings. I feel like we may have been talking about two different categories of patients there. The patient that Eric brought up as an example was a pediatric potential brain death. And then I think that what we were sort of talking about was donation after circulatory death type donors and how those folks are sort of ready to withdraw life support and how we can match our processes to their needs. And I guess the only thing that occurred to me as he was talking was that, and it's kind of an aside thing. It concerns me that there's a belief out there by any family that someone in their family was erroneously declared brain dead. And I think that a situation like that for Eric would require a little bit of digging to make sure that all of the right processes were followed. We have a pediatric ICU here, and we've done, I think, 2 pediatric donors within within the last month, 2 children under the age of 15 in the last month. And we have a very specific process for how this is done in terms of the number of providers that need to be involved and the timeframes of the timeframes of the assessments and the components of the assessments and the uses of ancillary tests. And I would hope that that family that Eric referred to, that there's some support there to take a look at how that could have even possibly happened, that a family was being pushed with erroneous brain death information. So anyway, I just felt like we were kind of talking about 2 separate.
Yeah, no, Eric would love to be able to follow up with you on that case in particular, if it occurred within our service area here. So LifeCenter, we just published a paper, Penny, about our efforts to ensure standardization of brain death policies in our service area, that they're following AAN guidelines to, one, ensure that the tests are being conducted appropriately. Thank you, Eric, said it wasn't our service area. And that we're reducing the need for ancillary testing, because if people are not waiting for appropriate time frame for normothermia, other paralytics are on board, or it's an and/or versus PCO2 rise and millimeter mercury rise. Those are things that we looked at variation in our brain death policies. So I'm happy to share the work that we've done, but we've really tried to make a concerted effort to making sure that we're partnering with our hospitals to ensure brain death policies are updated in accordance with AAN guidelines. So certainly pediatric population is separate from the work that we did. We are looking to move our work onto pediatric brain death testing, but it's outside of our service area. But to your point, I think we want to make sure that people feel confident in the tests that are being encouraged or that are taking place. So people have experience where there's a family member who was declared brain dead and then made a full recovery. That's a big gap in somebody's process. So. But I recognize a distinction there, Penny, between the 2 different patient populations. There are the donation after circulatory death, where timing is the #1 decline reason. So LifeCenter wants to ensure that we have the resources in place to make donation happen. Then there's also the cases that need to be slowed down to ensure that the proper testing is placed, that the family has the appropriate information, and there's and they understand the severity and kind of what tests are going to be coming down the pike from that pathway.
Any other questions or comments? So I saw Christy had put in the chat, I don't think I said this before, she was wanting to know about the slides being shared and just needing a little time to wrap her mind around it. So we will definitely be sharing the slides, as well as the recording will be available if anybody wants to rewatch it. And in addition, we will be putting out an FAQ where you'll have access to the language from the UAGA. We'll reference the document that Dominic shared from the national commissioners and their comments, so that all that will be available for you to review, also for your hospital's legal or risk or other administrators or leaders at your facility. We definitely want to make sure that you have access to all the information that we're sharing. And again, our hope and our goal and the things that we are working towards is to prevent as many registry oppositions as possible and be able to implement a process that allows families to both say yes to donation and meet whatever timeline they have in mind for end-of-life decisions. So any other questions or anything anyone needs related that I haven't mentioned that would be helpful as you go forward? Let's see, a link to resources, extubation timeout checklist. Absolutely, we can definitely get that for you as well. So we will have your HD PM reach out to you with those. And like I said, we will have the FAQs and some other things out in the near future. And then one last slide, we will be having our final Site Champion Roundtable of this year. It's going to be on December 6th, and we're really going to be sharing success stories, recapping what we've done so far, and looking forward to what we're looking to do in 2023. So we'll be sending out Outlook invitations soon, and we just really appreciate all of your support and your work and your commitment to this and for showing up to these every month. We hope that they're valuable, and if you do have any feedback or topics that you think would be helpful, please don't hesitate to reach out to your LifeCenter representative, because we want to continue to make sure that these are valuable for you and that you're getting information that is useful. And with that, I think that is all for today. So thank you for attending, and we will see you soon.